Hi Richard, how are you doing?
Oh, hi, Dr. Miscott.
So from our last discussion, we were going to actually follow up on the blood work you did with regards to diabetes testing. Type 2 diabetes is not an entity where you don't produce insulin. It's where your insulin actually doesn't work as well as it should act. What we have is a team that works with a diabetes patient. And because you have high blood pressure and high cholesterol, you're on a variety of medications. If we do decide to add medication for your diabetes, I will be actually sending you to our pharmacist to have a once over to make sure that there are no interactions and that you can actually handle all those medications. Typically, the patient will see myself and my RN, which is a physician RN team. There we discuss goals for treatment plan and goals for the patient's diabetes. And from there, we decide who in our interdisciplinary team may be of help for this treatment plan. So the people that we do have available to us are pharmacists, dietitians, psychologists, and other RNs or RPNs with specialty training in diabetes education. And with this team, we can give a patient a full complement of services. In short, it makes my life a lot easier because I don't have to be everything for every patient.
We had what seemed to us like kind of a historical opportunity. The government of Ontario had offered these family health teams to family practices, and team-based care was something that we in family practice had been thinking we wanted to do for a long time, so this was an opportunity to do it. Now we had a group of clinics and clinicians, the people in our university department who'd been working together for other reasons, for teaching, for research, for a good long time, and we thought if we're all looking at the same kind of change work at the same time, why not do it together? The four clinical areas, depression, diabetes, well baby care, and end-of-life care, are really common and important areas in family practice, and they were also areas that seemed to us that a team could usefully be applied to.
So I see you brought your medications with you today.
I did,
Great.
yes.
Can you tell me, do you know why you're here today?
Yeah, I'm here because a couple of weeks ago I got a diagnosis of diabetes, type 2 diabetes. And so Dr. Misdrak was thinking about medication for that, and since I'm already on a couple of medications, I guess I'm also wondering about side effects, whether there's side effects of the new diabetes drug or from the other drugs from taking them at the same time that I need to worry about.
I'm finding that the protocols work in a way that just helps the referral process a bit more. We've worked a lot in our clinic and in our family health team to provide or develop a collaborative care for diabetes. And these specific protocols allow us to work as a team and actually give us a bit more direction to kind of find out who should be doing what. And as a pharmacist, I find that it just helps us redefine the roles and responsibilities of the various health professionals in our clinic.
What it's really done is it's made us look at for four key areas. What is the evidence? What is the best way to approach well baby care or diabetes or depression in our practices? And I think that's what it's really made us do, is enhance the quality of our care by giving us the right tools, and then really thinking, well, who's the best person to use that tool?
Protocols were developed by people from all different professions, from all the different family health teams that we were working with, who worked from the clinical evidence that was provided to them about what constitutes best quality care. And they themselves outlined how this best quality evidence, how the jobs that needed to be done in these particular areas could be accomplished in our family health teams.
In our clinic, typically patients are assigned to a physician, and then that physician is part of a larger team. So we have two teams here at the Toronto Western, and we have a full complement of interprofessionals on each team. So typically that patient will be taken care of by the whole team. Although they are assigned to one physician, that physician is part of a larger picture.
So if the patient were to get referred to me, the patient will be booked to see the pharmacist, to see myself. I will do my assessment, and then I will actually communicate back to the core team, so that would be the physician and the nurse. If I have recommendations, with respect to changing medications or any other type of monitoring or concerns that I have, I will then communicate directly with the physician.
Thank you. Can I help the next patient, please?
Yes, good morning. I
Yes.
have an appointment with the dietitian.
Yes. Can I have your health card, please?
Sure.
Well, when a client comes to see me, they may be referred by another healthcare professional, whether it's the physician or perhaps social work. So I get a little bit of history. We've got all the information in one chart, so I can have my client interaction, but also be able to liaise with other healthcare providers that may be seeing the same client. So I get a really better understanding of the client themselves, the overall picture, and we together can work together as healthcare professionals to provide higher quality of care.
Hello, Mrs. Mills. Hello, Sophie. Hi, Juanita.
Simply put, physicians are hard-pressed to really spend a 10 or 15-minute visit on much more than physical and some of the really high priority issues that might come out. And this is a great opportunity for other team members to become involved in that visit and do a very comprehensive assessment of the child's developmental, social, physical, all aspects of their development. Well, it optimizes the physician's role, and it brings in other health professionals who are then used to full scope and are able to identify areas of concern and flag that and bring that back to the physician for their input as required.
The other things that may happen is in my visit, I actually may deem a concern with respect to the need for another healthcare professional. Even though we have a care coordinator, it's possible that I, as a pharmacist, could identify the need for a social worker involved.
Well, the depression screening tool essentially is a two questions that can be used by any member of our team. They're simple and straightforward. You don't need specific training or to be a mental health professional. It's evidence-based and is as good as any 6 or 8 or 10 questions. It's two simple, straightforward questions that are easy to memorize. There's an actual screening tool. It's called the Patient Health Questionnaire. So you could pull out, if you knew the first 2 questions and you were comfortable asking the remaining 7 questions to further explore what's going on in their life.
There's been a lot more uptake of our own advice to patients. So before there was a barrier to them uptaking, I think you'd probably benefit from seeing a social worker. I don't have coverage, doctor. Now that barrier's removed, and so the advice that we can give our patients can actually be done by our patients because there's no financial barrier for them. So those patients, they have to shift their expectations, but on the other hand, they're getting a higher quality of care.
Well, to be honest, I didn't know what it was going to mean for me to work with a family health team, but it's turned out to be a lot different from any kind of healthcare I've experienced before. For one thing, is been a lot easier, a lot more convenient for me. Everyone I needed to see is all in one location, so it's sort of like medical one-stop shopping. I've also felt a lot more confident because, for instance, when I needed to see a dietitian, as opposed to just having to pick a name at random out of the phone book, I just saw the dietitian who was a member of the team, and I knew that my doctor trusted all the members of the team, and that in fact all the members of the team were talking together about my treatment. So the bottom line is that I felt a lot more taken care of.
There are definitely patients that are always more difficult to deal with, and when you know that you're not the only person who's going to deal with those patients today, that you can share that difficult responsibility with another healthcare provider, I think actually makes your job a lot easier to deal with on a day-to-day basis.
It's provided a guideline for us to move forward, to put in a more formalized structure and process for caring for diabetes.
Well, basically the work's already done for us. The plan is based on evidence. We don't have to take the time to research that and create a new protocol.
There is some time up front, but once you've organized that, you can offload a lot of the what really should be medical doctor work to other members of the team.
The fundamental difference between this model versus previous models is that I can actually now spend more time doing patient care with the help of my team, and at the end of the day I can see more patients and I can provide more care to the community that needs it.